right, Dr. Matson here again. I uh, am going to cover tobacco in this PowerPoint presentation, and we will go over kind of its history and how it's moved throughout the world, as well as the effects to individuals that smoke, secondhand smoke, effects to the fetus, and other things. So, in the United States, tobacco is a legal drug, and we have more health effects than for people that use tobacco than are other alcohol and or drugs. Looking into the history a little bit, tobacco was unknown to Europeans when Columbus arrived in the New World in 1492. In fact, it was 100 years after Columbus's voyage before tobacco became popular anywhere in Europe. The short form of the story is that merchants and members of the clergy who spent time in the Americas trading with natives, eating meals, and sharing ceremonial occasions first adopted the use of both tobacco and chocolate. These people became wealthy and powerful members of society back in Europe, and over the years, the practices they brought back with them came to be associated with their status. Commercial importation of tobacco into Europe in large quantities began around 1600. Looking at some early medical uses, beginning with a few trials by physicians, recognition of the potential of tobacco grew during the middle of the 1500s. The French physician Jean Nicot became enamored with the medical uses of tobacco, and in 1753, Linnaeus, the Swedish father of taxonomy, named the plant genus Nicotiana. When a pair of French chemists isolated the active ingredient in 1828, they acted like true nationalists and called it nicotine. In the 16th century, Sir Anthony Shute summarized much of the available information and said, quote, anything that harms a man inwardly from his girdle upward might be removed by a moderate use of the herb. Unquote. Others, however, felt differently. If taken after meals, the herb would infect the brain and liver, and tobacco should be avoided by, among others, women with child and husbands who desire to have children. The slow advance of medical science through the 18th and 19th centuries gradually removed tobacco from the doctor's black bag, and nicotine was dropped from the United States pharmacopoeia in the 1890s. So, a couple major species that are related to nicotine. We look at, well, there's really 60 species of nicotine, but only two major ones, and that's the tabacum, which was indigenous only to South America, and the rustica, which is a small leaf species, and the plant existed in the West Indies and Eastern North America when Columbus arrived. The Spanish monopoly on tobacco sales to Europe was a thorn in the side of the British. In 1612, Rolfe somehow got seeds of the Spanish tabacum species, and then this species grew beautifully and sold well. The colony was saved, and every available plot of land was planted with the tabacum. Income from the sale of tobacco became so important to the English colonists that tobacco planting spread to Maryland, Massachusetts, and the other colonies. Some other types of tobacco would be snuff and chewing tobacco. So during the 18th century, smoking gradually diminished, but the use of tobacco did not. Snuff replaced the pipe in England, and at the beginning of that century, the upper class was already committed to snuff. The middle and lower classes only gradually changed over, but by 1770, very few people were smoking. And tobacco in early America played an important role in the Revolutionary War. It was one of the major products for which France would lend the colonies money. And after the war, ordinary Americans rejoiced and rejected snuff as well as tea and other things British. Chewing tobacco in 1860, only 7 of 348 tobacco factories in Virginia and North Carolina manufactured smoking tobacco. The amount of tobacco for smoking did not equal the amount for chewing until 1911 and did not surpass it until the 1920s. The start of the 20th century was the approximate high point for chewing tobacco, and the sales of which slowly declined through the early part of that century as other tobacco products had become more popular. Uh, then we moved to cigars, and the transition from chewing to cigarettes had a middle point, a combination of both smoking and chewing, which is cigars. Cigar manufacturers suggested that cigarettes were drugged with opium so no one could stop using them, and that the paper was bleached with arsenic and thus was harmful. The efforts of the cigar manufacturers worked for a while, and cigar sales reached their highest level in 1920 when 8 billion were sold. For cigarettes, Spanish peasants apparently started cigarettes use in Europe by shredding discarded cigar butts and rolling the tobacco in scraps of paper. And by the 1830s, the practice had spread to France, where the word cigarette was coined. The first British cigarette factory was started in 1856 by a returning veteran of the Crimean War, and in the late 1850s, an English tobacco merchant, Philip Morris, began producing handmade cigarettes. At the start of the 20th century, there was a preference for cigarettes with an aromatic component, that is, Turkish tobacco. Camels, a new cigarette in 1913, capitalized on the lure of the Near East while rejecting in it actuality. The first ad showing a woman smoking appeared in 1919, and king-size cigarettes appeared in 1939 in the form of Pall Mall, which became the top seller. Filter cigarettes, as filter cigarettes, not cigarettes that happen to have filters along with a mouthpiece, appeared in 1954 with Winston. This rapidly took over the market and continued to be number one until the mid-1970s. Filter cigarettes captured an increasing share of the market and now constitute over 99% of all U.S. cigarette sales. So tobacco under attack, as with every other psychoactive substance, use by some raises concerns on the parts of others, and many efforts have been made over the years to regulate tobacco use. In 1604, King James of England, the same one who had the Bible translated, wrote and published a strong anti-tobacco pamphlet stating that tobacco was harmful to the brain, dangerous to the lungs, and New York City made it illegal in 1908 for a woman to use tobacco in public. And in the Roaring Twenties, women were expelled from schools and dismissed from jobs for smoking. The long and slowly developing attack on tobacco as a major health problem had its seed in reports in the 1930s and 40s, indicating a possible link between smoking and cancer. A 1952 article in Reader's Digest called Cancer by the Carton, which drew public attention to the issue and led to a temporary decline in cigarette sales. The major U.S. tobacco companies recognized the threat and responded vigorously in two important ways. One was the formation of the supposedly independent Council for Tobacco Research to look into the health claims. The other response was the mass marketing of filter cigarettes and cigarettes with lowered tar and nicotine content. In the early 1960s, the U.S. Surgeon General's office formed an advisory committee on smoking and health. Its first official report, released in 1964, stated clearly that cigarette smoking was a cause for increased lung cancer in men. At the time, the evidence for women was less extensive. So per capita sales of cigarettes began a decline that continued over the next 40 years. In 1965, Congress required cigarette packages to include the Surgeon General's warning. All television and radio advertising of cigarettes was banned in 1971, and smoking was banned on interstate buses and domestic airline flights in 1990. The list of state and local laws prohibiting smoking in public buildings, offices, restaurants, and even bars grows every year. In 1995, the Food and Drug Administration announced plans to regulate tobacco. After a year of discussion, rules were proposed that further limited advertising on billboards and other public displays, sponsorship of sporting events, promotional giveaways of caps and t-shirts, and advertising in magazines with significant youth readership. We had people that began seeking lawsuits. Uh, One important attack on tobacco came from these lawsuits that were seeking compensation for health consequences of smoking, and for years, the tobacco companies had succeeded in winning such lawsuits based on the idea that smokers had a significant share of the responsibility for their smoking related illness. A group of attorneys representing individual clients joined with several state governments seeking compensation for increased Medicaid costs, and eventually 46 states reached a 1998 settlement with the major U.S. tobacco producers that included a $205 billion in payments to the states, as well as agreeing to the previously proposed FDA advertising regulations and a federally supported program to enforce laws prohibiting sales to minors. Looking at safer options, if we can say there are safer options for cigarettes. Nicotine appears to be the constituent in tobacco that keeps smokers coming back for more. If the nicotine content of cigarettes is varied, people tend to adjust their smoking behavior, taking more puffs when given low nicotine cigarettes. Another complex product of burning tobacco is something called tar, the sticky brown stuff that can be seen on the filter after a cigarette is smoked. Beginning in the mid 1950s with the mass marketing of filter cigarettes, the tobacco companies began to promote the idea of a safer cigarette without actually admitting that there was anything unsafe about their older products. The problem with all this is that safer doesn't mean safe, and it wasn't at all clear how much safer these low tar and nicotine cigarettes actually are for people over a lifetime of smoking. And then we look at electronic cigarettes, and several battery powered electronic cigarettes began to be imported from China in 2004. And these contain some form of nicotine liquid that is warmed by a small electric element inside the cigarette. The FDA attempted to ban these products, but in early 2010, a federal judge ruled that they could not do so. After the 1995 FDA proposals that cigarettes be regulated, it was not clear exactly how they could do this, since tobacco products had originally been excluded as neither food nor drug. And in 2000, the U.S. Supreme Court ruled that existing federal law did not give the FDA authority to regulate tobacco. The drugs that the FDA reviews and approves all claim to have therapeutic benefits of some kind, but what is the intended use or health benefit of a tobacco cigarette? How could the FDA balance the benefits versus the risks without someone defining the benefits? In June of 2009, President Barack Obama signed the Family Smoking Prevention and Tobacco Control Act, authorizing the FDA to regulate tobacco products themselves in specific ways. One important rule is that claims for modified health risk are now prohibited until such claims can be clearly demonstrated. In other words, a seller cannot claim that e-cigarettes or hookahs are safer than regular cigarettes. Also, all tobacco products will be regulated in a manner similar to drugs, and that the companies will have to apply to the FDA describing their product and its intended uses. Current cigarette use today, cigarette smoking is declining in the U.S. In 2015, Monitoring the Future study that was done among full-time college students 1 to 4 years beyond high school, 7% reported smoking daily within the past 30 days, compared to 17% for the same age people not attending college. So it's evident that this difference in cigarette smoking based on college education probably reflects the considerable influences of socioeconomic status, family background, and expectations, and apparently has little to do with any knowledge of a college graduate that they might have obtained, or differences in the type of employment after high school. Smokeless tobacco in the early 1970s, many cigarette smokers apparently began to look for alternatives that would reduce the risk of lung cancer. And pipe and cigar smoking enjoyed a brief but small increase followed by a long period of decline. Sales of smokeless tobacco products, specifically different kinds of chewing tobacco, began to increase. The most common type of oral smokeless tobacco in the U.S. is moist snuff, which is sold in a can. Most snuff is not snuffed into the nose in the traditional manner, but a small pinch is dipped out of the can and placed beside the gum, often behind the lower lip. Smokeless tobacco enjoys many advantages over smoking. First, it is unlikely to cause lung cancer. Smokeless tobacco is less expensive than cigarettes, and with an average user spending only a few dollars a week. Despite the Marlboro advertisements, a cowboy or anyone else who is working outdoors finds it more convenient to keep some tobacco in the mouth than to try to light a cigarette in the wind and have ashes blowing in the face. And chewing might be more socially acceptable than smoking under most circumstances. Many users can control the amount of tobacco they want to put in their mouth so that they don't have to spit very often. What they do with the leftover quid of tobacco is a different story and oftentimes not a very pretty sight. When we look at some hazards, though, it might not be as unhealthy. Chewing tobacco might not be as unhealthy as smoking. However, smokeless tobacco is not without its hazards. Of most concern is the increased risk of cancer of the mouth, pharynx, and esophagus. Snuff and chewing tobacco do not contain potent carcinogens, including high levels of tobacco with specific nitro. Many users experience tissue changes in the mouth with this whitening, thickening, and hardening of the tissue, a relatively frequent finding, and it is considered to be a precancerous lesion, a tissue that can change and develop into cancer. The enamel of the teeth can also be worn down in the abrasive action of the tobacco. Dentists are also becoming more aware of the destructive effects of oral tobacco. Concerns about all these oral diseases led the Surgeon General's office to sponsor a conference and produce a 1986 report called The Health Consequences of Using Smokeless Tobacco. This report went into some depth in reviewing the epidemiological, experimental, and clinical data and concluded that the oral use of smokeless tobacco represents a significant health risk, and packages of smokeless tobacco now carry a series of rotating warning labels describing these dangers. Looking at hookahs, these are large, ornate water pipes imported to the U.S. from Egypt and other Arab countries where their use has never completely gone out of style. Burning charcoal is put into the pipe bowl, and a piece of prepared flavored tobacco, or shisha, is placed on a screen over the charcoal. The smoke is drawn through a tube into a water reservoir by drawing on mouthpieces connected to the tubes that enter the hookah above the water. The water-filtered smoke is milder, and the social nature of smoking in this manner has led to some bars providing hookahs for their customers' use. Obviously, smoking has many adverse health effects. 50 years after the 1964 Surgeon General's report first linked cigarette smoking to lung cancer, it is now known that there are several other deadly diseases for which smoking significantly increases the risk. Although lung cancer is not common, over 80% of all lung cancers occur in smokers. It now appears that smoking is also related to about 30% of deaths from the leading killer, cardiovascular disease, or about 150,000 premature deaths per year. In addition, cigarette smoking is the cause of 80% of deaths resulting from chronic obstructive lung disease, another 100,000 cigarette-related premature deaths per year. The earlier the age at which one starts smoking, the more smoking one does, and the longer one does it, the greater the impairment. Smoking doesn't do any part of the body any good at any time under any conditions. We know secondhand smoke also has many effects. A great deal has been said and written about secondhand smoke, that is the inhaling of cigarette smoke from the environment by non-smokers. Research is complicated. The smoke rising from the ash of the cigarette, or side stream smoke they call it, is higher in many carcinogens than it is the mainstream smoke delivered to the smoker's lungs. Enough studies have produced consistent enough findings that the Environmental Protection Agency in 1993 declared secondhand smoke to be a known carcinogen and estimated that passive smoking is responsible for several thousand lung cancer deaths each year. The CDC now estimates that the secondhand smoke is responsible for about 7,300 lung cancer deaths and 34,000 deaths from heart disease each year. Most states and municipalities now have laws prohibiting smoking in public conveyances and requiring the establishment of smoking and non-smoking areas in public buildings and restaurants, and some communities have banned smoking in all restaurants. And, we see this woman smoking with her child in the picture. Secondhand smoke, we know, does damage to the lungs, but being around that secondhand smoke at such a young age is just going to cause more potential health risks. And some cities have banned smoking in the car if you have children in it. So, looking at smoking in other countries, the WHO, World Health Organization, estimates that tobacco causes 8 million deaths a year worldwide. In recent years, sales declined in developed countries. Advertising and promotions in third world countries resulted in large increases in exports of American cigarettes. Asians in particular seem to want American cigarettes, and one of the major efforts was to open Japanese, Taiwanese, Korean, and Chinese cigarette markets to U.S. imports. Smoking while pregnant, well, the nicotine, hydrogen, cyanide, and carbon monoxide in a smoking mother's blood also reach the developing fetus and have significant negative consequences. On the average, infants that are born to smokers are about half pound lighter than infants born to non-smokers. There's a dose-response relationship. The more the woman smokes during the pregnancy, the greater the reduction in birth weight. Smoking shortens the gestation period by an average of only 2 days, and when gestation length is accounted for, the smokers still have smaller infants. Besides the developmental effects evident at birth, several studies indicate small but consistent differences in body size, neurological problems, reading and mathematical skills, and hyperactivity at various ages. It therefore appears that the smoking during pregnancy can have long-lasting effects on both the intellectual and physical development of the child. The increased perinatal, close to the time of birth, smoking, attributable mortality associated with sudden infant death syndrome, low birth weight, and respiratory difficulties adds up to about 10,000 infant deaths per year in the United States. The demonstrated effects of cigarette smoking on the developing fetus are the same magnitude and type as those reported for infants prenatally exposed to cocaine, and many more pregnant women are smoking cigarettes than using cocaine. The pharmacology of nicotine. Nicotine is a naturally occurring liquid alkaloid that is colorless and volatile. Tolerance to its effects develops along with a dependency that led Mark Twain to remark how easy it was to stop smoking because he had done it several times. Absorption and metabolism. Inhalation is a very effective drug delivery system. 90% of inhaled nicotine is absorbed. In humans, 60 milligrams is a lethal dose, and death follows within intake within a few minutes. A cigar contains enough nicotine for 2 lethal doses, but not all of the nicotine is delivered to the smoker or absorbed in a short enough time to kill the person. The nicotine is primarily deactivated in the liver, with 80 to 90% being modified before excretion through the kidneys. Part of the tolerance that develops to nicotine might result from the fact that either nicotine or the tars increase the activity of the liver, enzymes that are responsible for the deactivation of drugs. Nicotine mimics acetylcholine by acting at several nicotinic subtypes at the receptor site. Nicotine is not rapidly deactivated and continues occupation of the receptor, prevents incoming impulses from having an effect, thereby blocking the transmission of information at the synapse. Nicotine first stimulates and then blocks the receptor. Nicotine also causes a release of adrenaline from the adrenal glands and other sympathetic sites and has in part a mimetic action. Additionally, it stimulates and then blocks some sensory receptors, including the chemical receptors found in some large arteries and the thermal pain receptors found in the skin and the tongue. Continuing a little bit from the last slide on poisoning, we look at the symptoms of low-level nicotine poisoning, which are well known to beginning smokers and small children behind barns and in alleys: nausea, dizziness, a general weakness. In acute poisoning, nicotine causes tremors, which develop into convulsions terminated frequently by death. With lower doses, respiration rate actually increases because the nicotine stimulates oxygen need receptors in the carotid artery. At these lower doses of 6 to 8 milligrams, there's also a considerable effect on the cardiovascular system as a result of the release of adrenaline. Such release leads to increase in coronary blood flow and increased heart rate and blood pressure. The increased heart rate and blood pressure raise the oxygen need of the heart, but not the oxygen supply. Another action of nicotine with negative health effects is that it increases platelet adhesiveness, which increases a tendency to clot. Within the central nervous system, nicotine seems to act at the level of the cortex to increase somewhat the frequency of the electrical activity to shift the EEG toward an arousal pattern. Inhaling while smoking one cigarette has been shown to inhibit hunger contractions of the stomach for up to an hour. That finding, along with a very slight increase in blood sugar level and a deadening of the taste buds, might be the basis for a decrease in hunger after smoking. Despite all the protests and cautionary statements, the evidence is overwhelming that nicotine is the primary, if not the only, reinforcing substance in tobacco. Nicotine has the unusual ability to act as a mild stimulant, helping people to stay awake and to focus attention, as well as providing a sense of relaxation. Being dependent on nicotine, a 1988 Surgeon General's report provided the dependence producing properties of nicotine in the form of a 600-page tome. This had been a traditionally difficult subject. Not many years ago, the psychiatrists were arguing that smoking fulfilled unmet needs for oral gratification and therefore represented a personality defect. The following conclusions of the Surgeon General's report was pretty strong. Cigarettes and other forms of tobacco are addicting. Nicotine is the drug in tobacco that causes addiction, and the pharmacological and behavioral processes that determine tobacco addiction are similar to those that determine addiction to drugs such as heroin and cocaine. Recent research is focusing on the role of genetic differences in how people respond to their first smoking experience and whether they develop a rapid dependence or remain occasional smokers. Wrapping up these last couple slides with how to stop smoking. When one is young and healthy, it's difficult, if not impossible, to imagine dying, being chronically ill, or having emphysema, so that one can't get enough oxygen to walk across the room without having to stop to catch one's breath. By the time one is old enough to worry about those things, it's difficult to change your health habits. All the educational programs have had an effect on society and on people's behavior. There are now more than 40 million former smokers in the U.S., and about 90% of them report that they quit smoking without any kind of formal treatment. One reason that it is so hard for people to stop is that a pack-a-day smoker puffs at least 50,000 times a year. That's a lot of individual nicotine hits, reinforcing the smoking behavior. Although most of these programs are able to get almost everyone to quit for a few days, by 6 months, 70 to 80% of these participants are smoking again. Prescription nicotine chewing gum became available in 1984 after carefully controlled studies showed it to be a useful adjunct to smoking cessation programs. And in 1991, several companies marked nicotine skin patches that allow slow release of nicotine to be absorbed through the wearer's skin. Nicotine lozenges are now available over the counter, and smokers can also get a prescription for a nicotine inhaler or even a nasal spray. Although the prescription drug Zyban has been shown to help many people. Till now, it's not known which program will be best for any particular individuals. If a person wants to stop smoking, they can keep trying programs. Odds are that eventually they will find one that works. And if you are someone who is trying to commit to stop smoking, don't give up. You can do it. There are plenty of programs out there to keep trying, but you obviously have to have the willpower and the desire to quit. So talk to family, to friends, tell people you want to quit so that they reinforce and, help you stay on track with changing your behavior. Thank you.